And every once in a while, I'll talk to them. Johnny, you are doing such a great job right now. You are doing exactly what you need to be doing. You don't need to do anything differently. You're doing exactly the right thing for yourself right now. And I'm just here to be the witness to that.
Hello, and welcome to this 6th episode of Death is for the Dying, a special season of the Life is for the Living podcast. I'm your host, Rebecca Richmond. Active dying is the last stage of life, when the body is shutting down, the organs are failing, and the breathing is getting slower and slower. For some, the active dying stage is over in an instant, but for those dying of slower diseases or just of old age, this stage can actually last for a couple of months. According to Barbara Karnes' book, Gone From My Sight, which Kathy mentioned in the last episode, every path to death is going to look different. But in general, when a person is 1 to 3 months from dying, they will start withdrawing into themselves, decreasing food intake, and start to sleep more. As they get closer to death, you will see more disorientation, more changes in heart rate and breathing rate. There'll be changes to the skin color, and they may stop eating altogether while decreasing their fluid intake. In the last day or two, you may see a sudden spike of energy, but this will fade, and you will see decreasing blood pressure. The hands and feet may turn purple. They will lose control of their muscles, and so they will be incontinent, and they'll also not be able to swallow. Their eyes may be glassy and half opened. One of the very last signs you might see is gulping for air, sort of like a fish out of water, and in fact, no longer being responsive at all. I talked a bit with Kathy about some misconceptions that people have about the actively dying stage.
What is something that you think most people, or in your experience, people don't realize about the dying process?
That it's a natural one, when it's not a violent, traumatic one, that it's actually a natural process of the body gently beginning to shut down all the different systems of our body. Basically, anywhere from 3 to 4 months, sometimes a little bit more, sometimes a little bit less, because each person is as unique as their birth. That transition is similar. So as people in their early years, and when I was in skilled, people didn't understand that when people began to stop eating and drinking, that they were beginning their natural shutdown. And folks, especially children, because people didn't understand, well, if you don't feed them, if you don't put an IV in, that they're going to die. Well, that really is true, but it takes, a journey to do it. And if the body is actually beginning a natural shutting down, closing down, if you will, a person does not hunger and is not thirsty.
Kathy also recommended a couple of videos, which I will link in the description, that are helpful to understand what active dying looks like. She also explained what hospice can do to make the transition easier.
So a comfort kit when people are getting really close to end of life, and we're talking probably days to weeks, and some individuals, especially with a cancer diagnosis, need pain medication. And so a comfort kit will include morphine, it will include Ativan, because that's an anti-anxiety, and it could also include atropine, which dries up all the fluids that people will have a gurgling, and it sounds terrible, and it can sound like it's a person is really struggling to breathe because it's gurgling. But that's because the end-of-life movements are slowing down, and so the atropine can help dry that up a little bit. And also sometimes a comfort kit will include an antipsychotic called Haldol. And there are a lot of vets that go through some real night terrors like nightmares, and it can be very frightening for everybody. And those kinds of medications, with the guidance of the hospice nurse will teach a family member how to use it. A lot of people are afraid about giving the last dose of a pain med that may cause the end of life. And really, what we're trying to do, the hospice team is trying to do, is help keep the person very comfortable without having a tremendous amount of breakthrough pain. And the breakthrough pain, if sometimes I hear this a great deal, is they're doing just fine, so we didn't give them any medication for the last 12 hours. Well, unfortunately, then that pain comes and it takes 2 to 3 times longer to get that pain well managed again. And so it's really hard. So the comfort kit that is supplied is under the auspices then of a nurse that helps teach the family members.
Next, I talked to someone who has plenty of experience witnessing people dying. Hospice volunteer Brooks Lewis. What drew you to volunteer to work with the dying?
I lived in Austin for a long time. I lived in Austin in the 80s during the AIDS crisis, and many of my friends were sick and dying, and there was no support. An organization called AIDS Services of Austin was formed to give support, things like going for groceries, taking people to doctor's visits, things like that, just sitting with. And so I became a volunteer in that organization for a while. So that's what really started it. And then eventually, I knew a lot of people who died. A lot of people died in Austin. Austin was the gay mecca of Texas, so you can imagine there were a lot of people there. And it was the whole idea of people dying alone, having to go through it alone. That was the main thing that people said over and over again. I'm just so glad somebody is here. Whether I was changing a bedpan or not was not the point. The point was just someone being there. As far as medical services, there were none available for a long time. There was one doctor in a city of 500,000 people that would even see a patient who was HIV positive at that point.
So now you volunteer for hospice in Las Cruces?
Yes.
And obviously that's a little bit of a different scenario. I'm assuming you're going more towards people who are dying of old age.
It just depends. One of the patients that I sat with last week was 31 years old. The care in hospice has really changed. I started there 6 years ago, and at that time, the majority of patients were there for weeks and maybe even months before death. And now they're there for days and sometimes just hours before death. They're being sent to hospice not as soon as they were before, which is something that as staff we talk about a lot. Who's caring for these people? And of course, we find out that if they're in hospital somewhere, and they're probably just not getting very much care because hospitals are really understaffed. And my experience talking to people who work in hospitals is that they haven't gotten the training on dealing with death and dying. It's not a part of their training.
Yeah, that's one of my concerns, particularly with like the boomers are coming and we don't have a lot of geriatric doctors, and even just general doctors, GP doctors don't get a lot of geriatric training. Not just geriatric, but like, yeah, as you said, hospice. So it feels like the medical system is very much underprepared for what's about to happen.
It's a part of the denial process. We see it on a personal level, but we also see it on a governmental level. And part of that is I call it the ongoing fallacy is, oh, somebody else is going to die, but not me. Somebody else, those people are going to die, and they'll be taken care of somehow, in some way. again, there's so much denial, ignorance about this stuff. And there's so much non-acceptance of reality.
I guess the question I want to ask next is, can you walk me through what it's like to sit with somebody when they are dying, when they're going through the dying process?
Okay. From the training that I've had, first thing that I do, if this is a new patient, one I've never met before, never seen before, when I enter the room, I knock on the door and go in and announce my name, tell them that I am a volunteer and that I am here to sit with them. Before I go in, I will have talked with the nurse or one of the CNAs to find out what the situation is. Is this person talking? Are they moving? I get a little report, so I'll have something in my mind about what I'm going to see when I come in the door. If they are just lying on the bed, which is the way it is most days now, and breathing, then I pull up a chair beside them and I sit down and I say, I'm just here to be with you. And I use their name again. And I tell them my name again. And then I just sit and observe. One of my duties is that I am eyes and ears for the staff. When I get through, I'll go back to the nurse or the CNA and have a little conversation with them about what did I see, what did I sense. And I've been working with the people there long enough that they honor what I'm telling them about what do I sense here, not just what do I see and hear, but what do I sense, even though there's no medical thing about that. But my job is just to be with. And what I do is, if I know what their religion is, which is I do sometimes and most times I don't, then I might be under my breath doing perhaps a prayer. If I don't know, then what I'm doing is I'm doing my Buddhist practice, my metta practice, which is just envisioning them in light and wishing them ease of passage. And every once in a while, I'll talk to them. Johnny, you are doing such a great job right now. You are doing exactly what you need to be doing. You don't need to do anything differently. You're doing exactly the right thing for yourself right now. And I'm just here to be the witness to that. I start out by saying that I wish them comfort. I wish them a feeling of safety. I wish them ease of passage. And I wish them finding peace. And I just kind of repeat that to myself, not really out loud, and just do meditation with those thoughts for as long as I'm in there. If there's a breathing change, and it seems to be a major breathing change, then I'll go and get staff immediately. And if there's family present, then I let the family do what they're going to do, and I just keep doing what I'm doing. But I'm not going to be as close to the bed, for example. I'm not going to try to push in anywhere. That's not my job. My job is not to push in. But most of the people that I visit with don't have any visitors.
I asked Brooks what he looks for when sitting with the dying.
We have a book that we're given as hospice training called The Dying Experience, written by Barbara Karnes. And it's a book that we hand to all the families, and then we also hand to the staff. And they have a list in there. This is 1 to 2 days to hours prior to death, and they list the things that might go on from their experience. The main thing is breathing changes. Because the patients in hospice are not intubated. They have breathing machines. They might have masks, and they have breathing machines, but they're not intubated. So their breath is pretty much whatever the breath is, right? The breathing pattern changes. It slows down, it speeds up, it has gaps. That used to be one of my jobs, was to count the seconds between breaths on the patient in the bed and write it down and see if it changes. Oh, if it's over 30, if it's over a 30 count between breaths, probably staff needs to be notified pretty immediately. And the sound of breathing, the rasp, especially if the person has congestive heart failure or lung cancer, some of those breathing things, their breathing is very noisy. And because they're not given medications, there is a medication that they're given to relieve the congestion at a certain point, but it really doesn't, because most of them are lying down. And again, if a patient is having a lot of problems with breathing, then I get staff and they'll turn them. As a hospice volunteer, I'm not allowed to touch the patients. I'm not allowed to do anything by law. Before COVID, I was allowed to hold their hand wearing a glove. I was also allowed to touch them on the shoulder. Again, I'm wearing a glove. COVID blew all that stuff out. In order to touch a patient who had been exposed, I had to completely gown from head to toe, including a headset mask. Looked like a spaceman coming into the room. And that was just, and so eventually they stopped having volunteers come in because it's just too much extra work. I'm a touchy-feely person, really, really hard not to want to just put my hand on somebody's shoulder when they're going through this stuff. So I have to envision it. I envision it as if it were happening that way, and that my hand actually was on their shoulder, and I can just keep talking to them. Because the main thing that I understand is presence is important. Even if the person appears to be completely out of it over there, they sense that somebody else is in there. And my guess is they might sense some intention in the person that's in there as well.
Yeah, I can see that being hard because, like, with my mom, she's not super communicative. She has dementia, but like holding her hand is like sometimes that's the best way I can communicate with her.
Absolutely, touch is important. I'm a touch therapist too, and the other thing is that their body changes things. They start getting colors, changing colors. It gets blotchy, especially knees, ankles, and elbows. And again, I'm not allowed to move the covers around to take a look, but I can see on arms and hands and faces what's going on, right? And I always report back to the nurses what I've seen. And they say, yeah, we've noticed that. It's in their chart already.
One of the big questions I have for you, like, I'm going to be honest, I've never seen somebody die. I've seen a dead body. I used to be an archaeologist. I've seen skeletons, but I've never actually been with somebody when they were dying. And I think there are actually a lot of people in my shoes who are now having to face watching their parents die. What would be your advice for someone going into that? What should I look out for so that I don't, I think one of the things that I've picked up on is, like, because people haven't experienced death, they freak out about every change and are a little bit more traumatized by death than maybe they should be.
Well, I wrote about that. I said to focus on being with rather than doing for. To focus on just being with the person. And that might be conversation, that might be, putting on some music, that might be. But the whole thing is that there comes a point where I have to remember that I can't do anything to change anything that's happening on that bed. It's going to happen. I can be a witness to that. I can honor it by telling them, you're doing just fine. You're doing exactly what you need to be doing right now. I tell them that a lot. If it's a man, I always say, you're doing a good job. Men like to hear that, right? But I say it for everyone. You're you're in the right place. You're in a safe place. I say you're in a safe place to do this work. And so go ahead. I'm here to watch you do this work.
And that is it for this episode of Death is for the Dying. Thank you for joining us. And if you want to join the conversation about death, you can reach us at lifeisfortheL on Twitter and Instagram, or email us at lifeisforthelivingpodcast@gmail.com. You can also watch these episodes on the Life is for the Living YouTube channel. And until next time, take care of yourself.